It's getting more common that lenalidomide is being used earlier in treatment. We're seeing it in patients who are being treated first line either as initial therapy in transplant ineligible patients or in maintenance therapy for patients who are transplant eligible. And so a lot of patients are now progressing on lenalidomide, which didn't used to be the case several years ago. So what that has led us into a situation of not knowing what to give these patients when they are refractory to lenalidomide and they've previously seen bortezomib. The OPTIMISMM trial was a phase 3 multi-center randomized trial comparing pomalidomide with bortezomib and dexamethasone with bortezomib and dexamethasone. And these patients would have had 1 to 3 prior lines of therapy. And it was looking at progression-free survival and overall response rates. As expected, patients did better with the triplet therapy, so they did better with pomalidomide, bortezomib, and dexamethasone over bortezomib and dexamethasone. But in the second-line subgroup analysis that they did with lenalidomide refractory patients and lenalidomide non-refractory patients, the lenalidomide refractory patients had a shorter response as compared to the patients who were lenalidomide non-refractory. They also did not have as deep a response if they were lenalidomide refractory. They also had a little bit more toxicity, so they had higher rates of anemia, and they did have somewhat higher rates of grade 3 and 4 neutropenia and thrombocytopenia, as well as a higher infection rate. There was almost a 50% decrease in death or progression with the addition of pomalidomide to bortezomib and dexamethasone as opposed to bortezomib and dexamethasone alone. However, the patients who were lenalidomide refractory did not do as well as the patients who were lenalidomide non-refractory across the board. So what this means is that for our lenalidomide refractory patients, pomalidomide with bortezomib and dexamethasone is an efficacious combination, more efficacious than using just the proteasome inhibitor with the dexamethasone. And it's also relatively tolerable. We did see that increase in cytopenias, including grade 3 and 4 infections, but that's with what we would anticipate with the toxicities, the known toxicities of pomalidomide, bortezomib, and dexamethasone. So I don't think there was any unexpected signals that came out of it from a toxicity point of view. So I think it's reasonably tolerable and certainly efficacious. So I think it is a good option for patients who have both lenalidomide and lenalidomide non-refractory disease. But for this increasing population of lenalidomide refractory patients, it does show that it's also an efficacious regimen for them as well. So it was a reassuring abstract. I guess it would be nicer to see them doing closer to the same as the lenalidomide non-refractory patients, but the results were promising for both. There was another abstract that came out of this that was looking at the quality of life, and Canadians have a big interest in the quality of life. Several years ago, there was a study that was done through the NCIC, the Myeloma 10 trial, and they looked at quality of life as part of that study, and that was a study of thalidomide and prednisone as maintenance therapy, and it did show that there was some improvement in the progression-free survival. However, this was not associated with an improvement in overall survival, and there was a decrease in the quality of life scores. So there is a bit of a Canadian precedent to try to look at quality of life, and certainly there's a move with many of these new therapies to look at quality of life as part of the measure of the patient benefit. So this was another analysis that was done looking at the quality of life scores with these patients using the EORTC Core 30 questionnaire, and looking at the patient's quality of life on pomalidomide, bortezomib, and dexamethasone versus bortezomib and dexamethasone. And what they found that there was no significant difference in the quality of life scores over the course of their treatments. And if anything, the POM, bortezomib, and dex group maybe had a little bit of an improvement in their quality of life scores over time from their baseline, but there was really no significant change or significant difference in either group. So again, this points to the tolerability of this regimen from a patient point of view, that we're probably not putting them through undue stress by adding the pomalidomide. And the nice thing is that it's an oral agent, so it's not that much more onerous from the patient point of view to add it onto the bortezomib and dexamethasone. So I think, again, that's reassuring that this is a reasonable option for this patient population. I think, again, from a Canadian perspective, it's nice to know that this treatment regimen is relatively safe and effective. in both a LEN non-refractory and a LEN refractory population, and the quality of life is reassuring, but the problem really is access right now. So hopefully this data as it comes out will support people being able to get access to this combination throughout the country, which is somewhat variable right now across Canada.